I think when we think of salivary diagnostics, I look at it as a way for me to really help my patients understand risk. And in life and dentistry and hygiene, we know what risk is about. We do risk assessments every day. And when you start looking at the foundation, the reason that sometimes we have disease or the reason and the root cause of it, salivary diagnostics helps us give us some more information for that. It's a matter of how does your body respond to the stimulus. So given a bad airway, given a bad diet, given all those other aspects, sometimes your tissues are going to respond more because of those other environments as well. We have to kind of look at the body as a whole, and it's a response to that biofilm and that bacteria. Salivary diagnostics for me definitely opened a whole new conversation of what's going on, and it gave me a different tool to communicate and help my patients, and it brought back excitement for me in my career.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, an Endeavor Business Media production. This is episode number 376. I am your host, Andrew Johnston, and thank you so much for making us a part of your day. And yes, I still have a little bit of a cold from last week, so I apologize about the kind of the nasalness of this message we're going to talk about today. And speaking of which, we have a wonderful episode with a truly amazing person. We have on Kerry Lepicek, and we get into a little bit of an intro of salivary diagnostics. She tells us a little bit about the importance of analyzing our saliva, some of the steps that we need for cultures, and what we need to tell our patients. It's really a great episode. And I can't stress the fact that this is such an intro to salivary diagnostics. If you want to learn more, she does a lot of speaking, so make sure you go check that out. And special thanks to Erica Flatteau for co-hosting again. I forgot to mention her on the last episode, but if you're wondering who that voice was on the last episode, it was Erica, and she'll be on a few more episodes coming up from what we did at Chicago Midwinter. So thank you to her for doing that. And then this weekend, we actually have a special bonus episode coming out with Sonia Dunbar, and it's on suction lines and mobile dentistry. So make sure you're coming back for that one this weekend. At least download it the weekend. You can listen to it on your drive into work next week. And then next week, we have our regular show that features Barbara Tritz, and she speaks about her experience as a holistic dental hygienist. It's absolutely intriguing, so you don't want to miss that one. A couple more things that we have that have come up since last week's episode. I wanted to catch you up with the fact that RDH Under One Roof is coming to Nashville in July this year. That part you probably already knew, but now what you probably don't know is there are over 1,500 people signed up already. It has been absolutely crazy pants. And from what I've been told, this is more than double the number of people that usually sign up about this time every year. So it is going to be absolutely bonkers. There is something absolutely going on in Nashville. I've also been hearing that some of the room blocks have been pretty darn full. So when I'm telling you to go sign up right this minute and get your room blocks, this is not hyperbole. This isn't a what do they call it? The scarcity effect or whatever. I'm trying to create a buzz. No, this is for reals. This is really happening. This is looking to be the biggest and best Under One Roof ever. And so I know you guys want to be a part of it. So make sure that you go over to the website, rdhunderoneroof.com, and sign up for it. Also, this is not a shame. However, there is a hygienist from every state representing except for Vermont. You, Vermont. So if you know somebody that is from Vermont, please, please, please wring their little neck and tell them to go hurry up and sign up so we have all 50 states represented at this year's Under One Roof. It's probably happened before, but I don't have any numbers on that one. So the second thing is that we are narrowing in on the details of that dental mission trip or dental relief trip that I was telling you about last week. So just a weird kind of like series of events that have happened. I messaged that tour group that I did with me and my sons, and I said, hey, are you interested in maybe partnering and doing this thing? And they said, absolutely. Because the thing that was stressing me out was I have to figure out, the food, the transportation, lodging, storage of equipment, all of the different things. in this particular case, translators, man, they have it all figured out. This is what they do. And they've been doing it for years and years and years. They have a lot of foreigners that come over with their group, a lot of English speaking. And so they have pretty much every logistical component that I'm looking for. They have it down. And so there's a couple more things I had to figure out. One is a cost, just to make sure that this is going to be financially affordable for everybody. I'm looking right now just to make sure that it's not going to be too crazy as far as cost goes. We also have to make sure the local government gets on board with this, because I think the first trip's going to be a little bit more low key. I'm not planning on bringing in a bunch of local anesthesia stuff and things like that, but that will be in the future something that we do. But even something like toothpaste, are they going to have a regulation about how much toothpaste we can bring in and things like that? So I think one of the best mission trips I've ever been a part of was the group called Somos Amigos. It's somosamigos.org. And Frank was the guy that organized it. It's been going on for more than 20 years. It's just amazing. And he has everything dialed in. And so from the moment that I got off the plane in Dominican Republic until the moment that I got on the shuttle to go back to the hotel, I really didn't have to do anything. He only asked that we have a small amount to cover expenses like hotel rooms and shuttle buses and stuff like that. And so I want to really try and model mine very similarly to his. I want to make this super affordable, try and get everyone to essentially pay their way and then contribute a small amount towards the group logistical costs. And hopefully we'll just make it super easy and it'll be fun to be a part of. So more to come on that as we get into it. Of course, the other thing I forgot to mention is with any mission trip that I go on, I'm a sightseer. I like to try new things and see new things. And so I definitely want to have that component of it. I've been to the Philippines multiple times. I lived there for a couple of years. I would love to share the things that I love about the Philippines with the people that come with me. And so there's going to be a little bit of touring kind of stuff as well. But this isn't going to be just like a whole tour and then a little tiny bit of mission work. It's going to be, a couple of days worth of serving the people. And I'll have my thoughts on what I want to do for another episode. But I think that's plenty for right now. I hope you're all having a great week, and please enjoy this episode with Kerry Lepicek.
A tale of two hygienists.
All right, welcome everyone into the interview portion of the podcast. So we're going to talk today about something that I learned a little bit more about yesterday at the AOSH meeting, but it still felt like a foreign language. So Kerry, I would love for you to help us figure out this whole salivary diagnostics. I don't even know how to this. I'm so inadequate about even asking a starting question. Where do we need to start with this conversation?
So I think that your feeling is exactly how so many people are feeling right now. And they know that there's this thing called salivary diagnostics, and they're just overwhelmed by even the thought of it.
Yeah.
And so I think when we think of salivary diagnostics, I look at it as a way for me to really help my patients understand risk. And in life and dentistry and hygiene, we know what risk is about. We do risk assessments every day. And when you start looking at the foundation, the reason that sometimes we have disease or the reason and the root cause of it, salivary diagnostics helps us give us some more information for that. And so I'm excited to talk to you guys about salivary diagnostics. I know it's not always the funnest topic. Funnest isn't even a word, I know, but it's not even a fun topic. But it is something that's so vital to what we do. We treat disease, and we treat disease without knowing sometimes that root cause. So we think that scaling and root planing is going to heal it. But if it doesn't, why not? We need to go back to the beginnings and figure out the foundational blocks, because what causes infection and inflammation is bacteria. So we don't have to be microbiologists. We just have to know, or we have to think about adding in it as an assessment to understand maybe why the patient's responding that way. And that's where it's changed my practice. And I've been using salivary diagnostics for 16 years, and it really did help me bring that mouth to the body connection for my patients.
Do you feel like you're using it on a lot of patients to begin with, or did you kind of slowly get into it? I'm thinking this one patient that I had to this day that still bothers me in a relatively low-ish perio population that I was seeing at the time. And he was a new patient to us, and young, and 8-9 millimeter pockets with no radiographic calculus whatsoever, significant bone loss. And I remember my doctor was saying, okay, well, we're going to do scaling and root planing. But I'm like, but why? What's going to happen with this patient after scaling and root planing? We know this isn't going to resolve. Can we just go send him to perio now?
And there's a couple, like handful of patients like that I can think of, but I would imagine that you probably would be doing it on a lot more than those few patients.
So where I am now, I do it on a lot more patients. And for some people, when you sit and listen to people lecture about salivary diagnostics, you get overwhelmed because you're like, oh my gosh, I'm not doing it on anybody, and now I've got to do it on everybody. How am I going to choose? And I think it comes down to planning your day or understanding your patient's needs. So start with a specific group that you're comfortable talking with. So maybe it is those stage 3 and 4 patients where they're starting to lose their teeth. We're seeing those deeper pockets. That's a great entry because they already have disease. We're comfortable in that zone. But there's also avenues and ways that I've used salivary diagnostics to help some of my patients that don't even have the presence of disease that we would see with pockets, which is assessing it with halitosis. Because some of our halitosis patients will present with bad breath, bad taste, and we look in their mouth, it's like, there's no bone loss, there's no deep pockets, there's not a lot of calculus, but it's a biofilm imbalance. And if we can rebalance that biofilm, we can generally then help to reduce the halitosis as well. So starting with a target market or target area, maybe it's your implant cases. Like we have patients that fail from implants, and we know part of that is occlusion, it's bacteria, it's everything. So why not get some more information, some more data, so we can better help have a predictable outcome with a positive experience where that implant stays in their mouth for their lifetime.
So we have case selection. We have a specific target that we're looking for. Is it a difficult process to get a sample?
No, it's so easy. And do you know what? So I was speaking yesterday at Hot Topics, and I was talking about salivary diagnostics. I do work with a company or a Vital, but the whole thing is that there's so many different choices, and that's what I love. You can have an opportunity to do a salivary diagnostics from spitting into a tube. You can do it with paper points. You can do it with a swab and paper points. There's so many choices. See what works best for you, but it's so simple for the patient. It takes about 2 seconds. Well, it doesn't take 2 seconds. Nothing in dentistry takes 2 seconds, but it takes about 1.5 minutes in total, probably from the time you talk about it to the time you have your sample. You send your sample in, and you get your reports back from all the companies. It's very, very simple for patients.
Can we have a little bit of real talk on that though? Is like, because I feel like, well, so it's not real talk. It's just that sometimes I feel like, oh no, it doesn't matter what company you go with. Is there a collection method that proves better than others, or truly it does not matter?
So
be honest.
So there are differences for sure. Okay,
okay. We're going to be political about this. Okay.
I'm from Canada. Okay,
I know.
I'm Canadian, and so I'm going to apologize for that right now. There we go.
Canada. Okay.
No, there are different techniques and there are different options. Sometimes I've found and I've heard. I've always used the paper points collection because I like that idea of personally going into the pocket, getting the sample from subgingival. And we, in the company that I work for, have always done a sample from the tongue. And so it's a tongue, throat swab, as well as a subgingival application or a sampling from the pocket. And so what that is, I feel like that's a true indication of the whole mouth. And I generally don't get any false negatives. So sometimes with different techniques, if the patient clears their oral environment, uses mouthwash sometimes right before, I've seen and I've heard from other colleagues that their samples came back with nothing. And so I feel like sometimes the technique is, if you sample from subgingival, if you're rubbing a surface, you're more likely to pick up some of that biofilm. Yeah. And so in that way, I think that there can be a difference, but my message truthfully is we want to test. We need to start testing to assess and to evaluate. So.
Well, maybe some of the hesitation is, okay, we're comfortable with performing the test, but then when we get the results, what do we do?
Yeah. Yes. And so I think, how do you incorporate that into your practice? How do you do that? There's different camps. So the whole idea is that the reason you want to test and the reason that I like to test is to evaluate those bacteria, some of those big bad bullies in the mouth, and I want to eliminate them because I know that those bacteria are linked with cardiovascular disease, with rheumatoid arthritis. They're starting to link it now with Alzheimer's and with so many other things. I don't want my patients to have that risk. So I know that scaling and root planing is not going to eliminate those pathogens. We move them around. We generally don't eliminate them. So treatment options can be lasers. It can be antibiotics. Antibiotics in a systemic form, antibiotics in rinse forms. There's a few different treatment options. Maybe it's a tray technique. There's lots of options out there to help reduce the pathogens. You just have to know what bacteria is there and then figure out from that what treatment option will target that bacteria. So when people ask me about mouthwashes, I always say, go back to the chemistry. What infection are you fighting? Choose the chemistry, choose the mouthwash, choose the treatment option that's going to target that bacteria.
Is there more like a broad spectrum rinse that will pretty much attack it all and just...
So you don't want to attack it all. That's the problem, is that you just don't. Like, if you kill it all, then you don't have a natural balanced microbiome. You need some gram-negative anaerobic bacteria to have a healthy microbiome, and everybody's going to respond to a different kind of bacteria. So I think that using a more of a targeted, selected approach, most people will generally use metronidazole to target the gram-negative anaerobic bacteria, and that in itself has been very efficient. There's tons of literature on the use of metronidazole and the reduction of the gram-negative anaerobic bacteria that we're testing for with Salivary Diagnostics.
Fantastic. That's a good answer. See, that wasn't too neutral. Okay, next one. So can you kind of run through, when it comes back to me, am I going to be able to read it, first of all? And what is it testing for, and what is a good and what is a bad number for those things?
Yes. So when you get the report back, it comes back in a bar graph. So you've got this visual aspect that says, okay, these are the pathogens that are present, and there's something called thresholds. So they are well outlined on your report that say, at this threshold, at this bar, at this mark, anything above that is considered a risk or is really not a great number. Depending on the bacteria, that number will vary. So each bacteria have a specific amount of threshold or a specific amount that you can have before it's deemed concerning. The thing I want to bring forth when you read the report, I'm really glad you asked me that, is because these bacteria are all sitting in the mouth, and most people read it as, I don't have PG, or I have AA, or I have FN, but all of those are like spices in a stew, and it's a matter of bringing it all together. It's how do all those bacteria also interact together. So it's not just those individual numbers, it's the combination of those bacteria in a response, and we see those clinical symptoms and signs. So yes, it's simple to read a report once you understand that, and each report usually also has infographics that are associated with it, so you can take that information saying, okay, you're linked with PG, and look, this is also linked, you checked off cardiovascular disease, and look, this bacteria is associated with that. And this is why we want to not only have your mouth healthy, we want to help you have a healthy heart.
I love that. I'm an infographic kind of guy. Like, let's just really spell this out for Andrew with pictures, because that's how he understands things.
But that's what people need, because the thing is, it's great. It's a new area, and people don't adapt these things because they seem complicated. So when you get your report back, it's like, reach out to the company, reach out to someone like myself, say, okay, Kerry, I got this report. How do I say this to the patient? And that's really what we're there for, to help as well, because you're adapting a new technique, a new conversation, and you've got to be comfortable in that. And so the graphics are helpful. And let me tell you, patients just have to Google, I have P. gingivalis, and they're going to come back and say, okay, I want it fixed.
Yeah.
Let me figure it out. And then that really opens that conversation. And with COVID all around us and everything else, post shutdown, patients are more open to this conversation. They want to know about their health. They want to know about testing. They're used to sort of the idea of, do I test to see if I have COVID? It's like, why can't I test to see how concerning my periodontal condition can be?
I was going to ask you about yeast. So I loved when I heard you say that we're all used to that textbook picture, well, this is what it's going to look like. And then also, can you speak about how it impacts the bacteria too?
Yes. Okay. So yesterday with Hot Topics, I was asked to kind of highlight a little bit about yeast. And I've been looking at Streptococcus, and I've been looking at Candida albicans in the testing technique that we've been using for 15 years. So I am a very small expert in this aspect. Okay, there's still lots of information to be had, but we know that we will see Candida in healthy looking mouths, and that's what shocks people. And if we think of what Candida can do, it can create inflammation, it can create the redness, that spontaneous bleeding, and we're thinking of that textbook picture to know that they have a yeast problem. But often people have that subclinical yeast infection in their mouth, and what that leads me when I read those reports and see that there's yeast, I ask them, do you have athlete's foot? Do you have any yeast concerns? Do you have chronic yeast infections? Because that yeast is not only in their mouth, it could be potentially systemically. And so bringing this connection together, because yeast is also able to cross the blood-brain barrier, and this is the problem. They're finding it so implicated with so many other aspects. And Yeast as well, I like to describe it to my patients as like a spider web. And so it's sticky, and the bacteria are able to come in and hide and create an environment behind it to grow. So we now are seeing yeast and strep mutans for early childhood decay, geriatric root decay. There's also some early models talking about P. gingivalis and yeast working together. And again, creating that outer layer around PG so it can kind of hide and grow and prosper. And so we not only need to target our gram-negative anaerobes, we need to look at more. We need to look at the yeast components, we need to look at the strep mutans families and the gram-positive bacteria in the mouth and try to have it as balanced as possible.
Wow. Well, very informative for me. I did not realize that. I was going by the textbook picture.
And that's what surprises a lot of people. It's like, you go by this textbook picture, you learned it back in school and you expect that, but it's those small amounts. And I was talking with some people at dinner the other night, and I said, everybody's going to respond differently. You're going to see some reports that have a very little bit of bacteria that were found, and you're like, well, did it fail? Like, what's going on? But everybody has a different immune response. Mm-hmm. I have this lovely friend, Andrea. We used to go out for lunch together every day before she moved on from my office, and she'd eat French fries and gravy every day and didn't put on a pound. Kerry, by the end of the week, could barely fit into her pants, okay? And so it's a matter of how does your body respond to the stimulus. So given a bad airway, given a bad diet, given all those other aspects, sometimes your tissues are going to respond more because of those other environments as well. We have to kind of look at the body as a whole, and it's a response to that biofilm and that bacteria.
Is there any benefit to doing like a sampling? Like they come in once, and then they come in a month, and they come in 2 months without any interventions in between? Get more accurate diagnosis.
You could totally do it that way. I think that you would want to I like to do it as test it and then check to see if my treatment or the suggestions worked, and then evaluate it after, because they are expensive. The prices range, from $50 to $150 for lab fees. And so it's not something that if people had infinite money, let's just have some fun. Like if you're Kerry and you've got a friend named Beth who loves lasers, you test the bacteria and then you laser it in the same day, and then you test the bacteria again just to make sure it works and kind of have fun that way. But most people are not necessarily in that zone. So what I would say is
she's got money for days.
Yeah, she's got money for days. Okay, Erica, you and I are going to hook up and we're going to do some fun tests. Let's use this and then test right after and see what goes on. But most people will test, and then they'll provide interventions or therapies, and then they'll retest after, just to confirm a balanced biofilm or understand how far they were able to go with the reduction of the bacteria.
If I was Michelle Hudson helping to interview you right now, and because she bailed on us, we're going to throw that out there. And I just love everybody, and I just love this, and this is the best topic, and this is my dearest friend in the whole entire world. What question would she be asking you right now that we're not asking? Because we don't know the subject as well.
I know. So she would say, so tell me about why you got talking about this and how it all started.
Yes.
Sorry, Michelle, I love you too. Okay, I really do. I'm your Canadian and you're my Texan. I know that, okay? That's our claim to fame. She loves everyone, but I am her Canadian, so nobody else can take her Canadian claim, okay?
We're not gonna hey, but also, let's do like a little light test. Let's not tell her that we talked about her on this, and then wait for that phone call to come through if she ever listens to it. And if she doesn't, then she's in big trouble if she never listens to the podcast.
Yes.
Especially this one.
Yeah, good call.
Okay, let's do that.
So nobody tip Michelle off that we're talking about her, okay?
Yeah.
Please, nobody tip her off. All right. So she would ask me why I got in. So I actually started looking at salivary diagnostics for halitosis reasons, and it was very eye-opening for me.
Sorry, for your own halitosis reasons or for your patient's halitosis?
For my patient's halitosis reasons.
Okay.
However, I did suffer from tonsil stones, and I learned a lot about tonsil stones and bacteria and everything else that way along my journey. Mm-hmm. But it was really that initiation of looking at patients differently was really how I started into the salivary diagnostics journey, looking at our halitosis patients and realizing that they may not present with bleeding and they may not present with a lot of plaque when you disclose, but they have significant high pathogens and really, really horrible breath. And so it was about measuring that and offering an opportunity to help them, because a lot of these patients suffer so significantly and they are at their wits' end, and they come to us. And I had patients, they came to me and they're like, oh, I come in every 3 months and I put up a sign that says, if you've got concerns about halitosis, we can test it now and we can evaluate it. And the patients just would point to the sign and be like, help me. I have this. I'm like, I had no idea people had these problems in our practice. And so once I started looking at the bacteria, I had more reasons or opportunities to offer the right interventions or reduction of the bacteria. And it really did impact our life. And I shared yesterday at AOSH some stories about how I've used it and changed my practice. And with all the information we know about pregnancy, adverse pregnancy outcomes, and bacteria, I had a situation where I had a pregnant person in my chair, and I had to kind of have a polite conversation with them about their FN being really high. And that was awkward, and I never wanted to do that again. So what I've learned is now, before I have people that are looking at expanding their family or are wanting to have kids, I try to offer them the test. I try to say, let's reduce your risk. Let's reduce those bacteria as much as we possibly can, so then we can have a better outcome for you and for your newborn baby. So that's sort of how I started and where it is today, I guess I can say.
So you mentioned FN. Is there one of, FN, what is it, AA, PG, whatever
TD,
other?
yeah.
What's the other one? There's 5?
Well, yes, here, I wrote them all down here for you. So we've got AA, PG.
We're saying together, AA, PG, TD,
TF,
and
TD.
Wait,
and then,
you did TD twice? Okay.
Oh, I do have TD
then
twice.
FN.
Yes, and then PM or PI are also tested in different types of companies, and then we look at strep and we look at yeast.
So of this grouping here, is there one that is like, oh my gosh, like if that one's out of balance, like we're screwed? We
know PG really sort of starts the whole journey in most of the conversation. So we don't like to have PG there. PG, FN, if those top 5 players are at the game, we got a problem. We got to reduce the bullies. Like there's just way too many bullies in the playground altogether. And those 5 pathogens also, can be harder to control with just scaling and root planing. So we have to look at other opportunities and avenues to reduce the pathogen load. And if we get rid of the pathogens, if we're able to reduce that, we're going to reduce the host immune response and how we respond to it, and we're going to have a healthier person and a healthier microbiome.
Is this mostly happening in the hygiene chairs, or is this mostly happening in the doctor's chairs?
So depending on the office setup, but most of the time it does fall into the hygiene chair, for sure.
So if, let's say, okay, I'm a hygienist, I want to introduce this into my office, how does that conversation go with the doctors? Because I don't think the doctors know this, just like we don't know this.
So that's actually, again, another very good question. I think the way to go about it is doctors want to know what's right for patient care and also what's going to be right for the office. And I can tell you, from focusing on the oral systemic conversation with my patients are more loyal. They're more likely to accept the care that I need. They want the infographics, the images to kind of prove a little bit of what we're saying. And so those are the avenues that I would approach with my doc and say, listen, I want to perform the right care. I want to make sure that patients are healthier, they stay in the practice, and they refer people. And people will talk when they find out that you've done this or you're doing something different. Many offices are looking for innovative ways to promote themselves and promote their services. So why not say, hey, we're trying to go after the root cause. We're doing more than just your scaling and your root planing and your polish. Yes, that's standard here, but we're going a step further if you show signs of risk, if you show signs of concern. And so that's how I would look at it. There are codes that work with it, because that's also always a question, like, how do you bill out this, right? Is that going to come out next?
Yeah.
So there are codes that work with it. Some insurances cover it, some don't. But I think the truth of it is it comes down to offering. If we withhold the opportunity for patients to say yes or say no, it's on us. But if you offer it to them, they have that choice. And I've worked in insurance-driven practices. I've worked in non-insurance-driven practices. And people just have to know what it is. And if they value it, they will pay for it. They will pay for the Starbucks coffee. They'll pay for the sunroof in their car. They just have to know that they need to value it.
Is Tim Hortons not expensive? Is that why you went Starbucks on that?
Yes, totally. Tim Hortons is like $1.50 coffee, and Starbucks is like $5.
Oh, but isn't Tim Hortons pretty good?
Tim Hortons is awesome. I'm sorry. If you have never been, yes, thumbs up, exactly. If you've never been and tried a Tim Hortons, if you come to Canada or you're close to that border, definitely check it out. I'm a tea person, so I love their steep tea. I'm very excited by that. And their donuts, of course. They're Timbits. They're little Timbits, exactly.
All right. Well, that went off in a weird direction there. Sorry about that. All right. So, okay. I am interested. I'm listening to this podcast. I want to take a class or a course. Where is a pretty decent course to find?
Well, you could check out any of the courses I may be giving,
Okay.
and that way, of course, but
I thought we were going to be neutral. What happened?
Oh,
No,
we
just kidding. Come on, Canada.
I didn't say where they were being held. Okay, there we go. I was kind of neutral. I'm like, you can Google Kerry and find her.
Oh, my gosh. No.
You know what I would say is the truth, as I said yesterday at the AOSH, reach out to the different salivary diagnostic companies. Each one will have a different panel, a different way. And I think you can learn a lot from talking to these industry leaders, these industry innovators, and see what works for you, honestly, because what works for one may not work for the other. And some love the spit test, some don't. Some like the paper points. So it really comes down to a conversation.
I like that. I had that approach quite a bit. 'Cause sometimes hearing it in a different viewpoint or in a different tone or a different sequence of delivery of information or whatever is just, you start learning stuff differently. So.
And everybody will have a different way of explaining it or a different angle. And
Sure.
I find that the more you can talk and communicate that way, I think the better off you will be. And I'm so excited to see that salivary diagnostics is really starting to come into a bit more mainstream. We're hearing a lot more about it. So as you attend seminars, you'll start to hear the dropping of, we're starting about this, or have you thought about the link about that? And the testing will be part of that aspect.
Nice. Any last messages for our listeners?
Okay, yes.
Okay,
Yes.
I have another question after that then.
All right. My message for you is just to don't get stagnant in your hygiene career. I think that what we need to do is we need to keep moving forward in the tough times that we're in the US and in Canada. I get to talk with a lot of different hygienists, and they're sitting there saying, I really am not sure if this is for me. And it breaks my heart to see so many people leaving the profession when I am so excited about it after 20 years. And so if you're feeling stagnant, if you're feeling like you're overwhelmed and you don't know where to go, think about the protocols you're using and think about trying something different. What do you have to lose? And so salivary diagnostics for me definitely opened a whole new conversation of what's going on, and it gave me a different tool to communicate and help my patients, and it brought back excitement for me in my career.
Okay, well, I'm glad that was your advice because I was actually going to ask you, like, what other things are you, like, super interested in? Because you are fascinated by things that don't come on my radar. What else is, like, interesting in hygiene to keep me excited and engaged?
So I love disclosing. I love all things about disclosing and patient education and assessment. And that's really where I thrive. And that's sort of the journey, looking at salivary diagnostics, looking at indices and different options that you can kind of show and involve your patients in are some of the kooky little things that I love to spend my time reading up on and finding opportunities. Oral systemics are another aspect of definitely my love, that communication, diving into that literature. And what I find fascinating about that literature is sometimes it's, what does it make me do? So when next time you're reading an article, think about what that conclusion says, and then think about how that's going to change your thinking. Whenever you're reading something, it's like, hey, what am I going to do now that I read this? Am I going to think of my patients differently? Am I going to act earlier? Am I going to change the products I use? You've got to come up with an action item after that. And so that's part of what I love to do, is to challenge hygienists to do that sort of stuff.
I love that. You have a lot of platforms. Where can people find you?
So you can find me on social media through Instagram. I'm Kerry Lepicek, K-Lepicek. I work with Aura Vital, so we do the salivary diagnostics. We are out of Canada, but we have our lab in the United States. I'm also involved with Women in Dentistry. I'm the section editor there for the Hygiene Corner. I'm on a hygiene talk show called the RDH View, where we give, once a month, we interview different people and kind of bring education to your view. And most recently, I am on the advisory board for AOSH, American Academy of Oral Systemic Health. So lots of different opportunities and options to kind of check me out. But yes.
Love it. I love it. Well, thank you so much for being on.
Well, thank you for giving me the opportunity. I know salivary diagnostics is not very much fun for most people, but I just think it's time that we start testing. If you don't test, you don't know. And there's lots of options. So choose your avenue, choose your patient. Maybe it's that stage 4 patient. Maybe it's your gingivitis patient. Maybe it's halitosis patient. Find something and just start. You won't improve. You won't get comfortable with it until you start doing it. So I encourage you to do that.
That's perfect. Thanks.
Thank you for having me.
Thank you.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental dental knowledge, and we do it all with ease. We cover oral health and screening and preventing gum disease. We're gonna do a lot of learning and have a little bit of fun working at the dentist. A tale of two hygienists.